So the topic of today's talk is when to know when treatment is complete. I'm Michael Connolly. I'm the medical director of Elevations and a psychiatrist.
And I'm Matt Seelos. I'm one of the primary therapists here at Elevations. Upon enrollment, a student will meet with Dr. Connolly and he'll perform his assessment, and then I'll meet with the student as well, and we'll compare our social histories and the information we gathered, and from that we typically try and identify top 3 goals that we're trying to focus on with a student. Some students are more willing than others to identify the goals that they need to work on or the reasons that they're here, and others it's helping them kind of understand they might not necessarily be open to this, and it seems like it might be beneficial in the future if they learn how to manage their mood or emotions, communicate with parents, etc.
So the question was, how do we start the process here at Elevations? And as Matt said, in general we're both going to meet with the resident. I'll be calling the family, so will Matt or whoever the therapist is, and we'll be trying to gather a history of what's gone on, what treatment attempts have been made, and start the process of creating a treatment plan, hopefully that includes the student with some top goals and some things we might eventually need to get to. So part of the treatment plan for many students would be medication management. And that can look a lot of different ways over the course of treatment at Elevations. Anywhere from students coming in on way too much medication because we've tried to avoid this level of care, to students who refused medication and aren't on any, or family systems that don't feel like medications are an appropriate approach. We take all sorts of entrances there. So in general, I would say that I'm fairly conservative and our team is fairly conservative on medication management. We don't tend to make changes unless there are side effects early on. We want the adjustment period to happen so we aren't confusing adjustment with medication effects. So it's often after a few weeks that we're starting to really dig deeper on our changes necessary at that time. And that will always involve the treatment team. Matt and I, or the rest of the team, will talk about what are we seeing, what symptoms are there, and what's the best treatment approach. And sometimes that's medication assistable, and at times there's really not something that medication is going to do to help this specific process. For example, a medication can't create social skills for me. That's going to be a different treatment approach. I would say on average, the residents who come in on a lot of meds are certainly going to leave here on less, and the ones who come in on nothing are going to generally leave on something in many cases. We do have probably 10% of our population that's not on medication and will never be, and that's perfectly fine. The goal is that their treatment trajectory is to improve and heal and be able to go someplace that's lower acuity. If medication is part of that, great. If it's not part of that, great. We just want the healing to occur. So that's my overview on how medication management works over the course of treatment.
And oftentimes my job is to give updates in terms of what am I seeing. Oftentimes I'll have a student who complains to me about a side effect but doesn't mention it to Dr. Connolly, or vice versa. And so deciphering, is this that they really are in need of help, or are they looking for something to maybe alter the way that they feel in maybe not such a healthy way. But yeah, my job is to give observations of what I'm seeing and what the student's reporting to me. So the question is, as students come in, sometimes they're in issues that maybe hadn't been identified when they first arrived, or as they gain more comfort, they finally feel the trust to open up and talk about something that they haven't shared before. I've had a number of individuals that, as the course of treatment's is going along, they open up and share that there's been some abuse or neglect or different events that they've been too ashamed to talk about usually. And so that's where we adjust the treatment plan to focus on that, and better recognizing that maybe these behaviors are in response to past behavior rather than what we initially saw as opposition or, guardedness. It might just be because they hadn't felt comfortable talking about what was going on.
In general, we see kids, we see teenagers come to Elevations when a lot's gone on. It takes a lot to want and need your child to be in a place for a long time, potentially, working on issues that we just haven't succeeded with at home. And what I would say on a lot of the behaviors, a lot of the negative things that we see, the purpose deep down is they want to feel different. They're hurting. And so whether that takes the direction of promiscuity or drug use or self-harm or suicide, I want to feel different. And we've got to move past those behaviors to get to the meat of the issues that are causing them to want to feel different right away. And that evolves over time. That's not an easy process to gain the trust to do. We provide a lot of containment and environmental safety so that work can happen when it just wasn't possible at home or at some lower acuity setting.
So the idea of the role that the family plays in being prepared for discharge, what that might look like in the process, and then once the child returns home, I think is really important. I stress with my families that the family is a system, and we need to work on all parts of that system, not just focusing on the child, because sometimes they are the identified patient. However, the family is really the patient. And so it's going through and helping them recognize maybe their struggles with validation, with being able to set clear limits, understanding that you can still validate how someone's feeling and hold an expectation for them. And so a lot of times it's going through and recognizing we need to change the way things are set up at home. We need to have clear limits. We can't just let little Johnny or Susie do whatever they want. They're looking for someone to say, hey, there's the edge, you need to stop.
As far as my perspective on family work, one of the things I will commonly, basically always, tell families when I'm first talking to them is that I view them as having PTSD. You don't get to this level of care without things being traumatic. They've been big. And so from a family perspective, one of the things that parents have to do, or siblings at times, they've got to heal. Because when we go home, we don't want to have a moment of regression, also have the weight of 1,000 similar behaviors from prior to coming to Elevations. We need to be able to see them in and of themselves in the moment. And so oftentimes it's very healthy for parents and families to be involved in their own therapeutic work so that they're not triggered as easily. And we don't have a clash of emotions. It's one of, okay, we're struggling in the moment, what can we all do about it? And that's an area we also end up practicing throughout treatment and Elevations. We move toward practice with families. We've got to do that in order to see how it's going to work and figure out some of the pitfalls and come up with solutions. So that often takes the shape of progressively longer absences to go work on that with families, whether that's local here or at home or a vacation somewhere. The setting just depends on circumstances at that point. And in terms of eventual discharge, it also helps to assess where are we at in terms of living at home. Do we need a intermediate step, a step down program, a boarding school, or something like that? And all of that certainly will change the timing of when it's appropriate to leave Elevations, but are important factors.
I think as students are getting ready to transition out of Elevations, we're looking at what is going to give them the greatest chance of long-term success. And so that might not necessarily be returning home. Sometimes we're going to look at an intermediate step, such as a young adult transitional program. We might be looking at a therapeutic boarding school. Sometimes it is going to be going home, but with in-home services in place. But really we want to have as much scaffolding around the student when they get to this new place, because change is difficult, and that's when we revert back to old behaviors. And so as we see that the child is succeeding, the family is succeeding, then we can start to pull that scaffolding away. But it's important that we have that scaffolding in place. And so it's working with the family to identify what are the needs that you're going to have while you're at home in terms of a therapist, support group, AANA, community involvement, education, what kind of academic setting are they going to need. And so it's looking at all those different aspects and making sure that they've got the necessary supports in place.
Thoughts that I have in addition to Matt is I will often tell residents here, teenagers and their families, it's easy to go home. What we're really wanting is not to need to come back. And so making sure that we've got the support necessary, whatever that looks like, whatever wraparound services or other things that can assist the process of reintegrating wherever we're going to be, those are important to have in place. The other component of that is how we determine readiness here within our system. And part of that would be moving up, showing more leadership. There's some levels that indicate that. The other thing that I tend to look at it with is through the lens of what we had in medical school mantra per se. And that idea was, first you got to hear about doing something. I've got to hear about a surgery. Then I've got to see it. I've got to see the surgery happen. Then I've got to do it myself. But I really have good understanding when I can teach others. Where that happens here is, if we take coping skills. Well, first I've got to know what they are, then I've got to practice using them. It's when I can tell other students what I'm doing, how I'm involving involving multiple skills, why I chose those, what I did next. Being able to talk through that means that we really have it down, and it's likely to be generalizable to situations that aren't happening. I can figure them out because I've got that knowledge base to do. And the hard part with all that is we've usually looked like we're behaving pretty well and doing pretty well for a while that process is happening, that really being able to teach it process. So the pitfall there for families is we've got a teenager who's, from the outside perspective, doing pretty well. How do we gauge that internal progression when we don't have big events, we don't have self-harm, we don't have other things happening to say we're not ready? And that's where I look at our team and the families. We're a village. We've all got to put our gut feels in there. We have the visits with families to try to practice in another setting. We increase leadership opportunities and responsibilities here. We try to do that with other teams or new people. The more we can adjust those expectations and areas to practice, the better we're going to be able to see just how generalized have those skills become. Just like we need our self-esteem to improve, and we've got to manage interpersonal, relational, emotional boundaries. Those are all core features that aren't going to be listed on a diagnostic label, but are probably more important in many cases than any DSM-5 diagnosis. And why I view therapy, frankly, as more important than my medication management all the time. We've reached the end of this talk, so obviously we haven't hit everything. This is a short amount of time, and there's probably questions that are going to arise, and we expect that. So that's where reaching out to our admissions team, with any questions you have, write them down and let's talk about them. Let's figure out how to meet those needs, how to give the information you need.
Yeah.
Thank you.
Appreciate you taking your time to listen to us.